Good day, and thank you for attending our webinar, Molecular Diagnostic Approaches to Accelerate and Improve STI Diagnosis and Research. The webinar is sponsored by Thermo Fisher Scientific. In today's webinar, we're going to discuss the importance of STI testing. We're going to learn about the main pathogens that cause STIs, and then we're going to discuss the Applied Biosystems portfolio related to STI and vaginal health testing solutions. My name is Teddy Proctor, and I am a Senior Scientific Affairs Manager at Thermo Fisher Scientific's Genetic Sciences Division, and I am the moderator for today's webinar. I'm very happy to introduce our speakers. First up will be Dr. Vanderpool. She is a professor of medicine and public health at the University of Alabama at Birmingham, and she's the director of the UAB STD Diagnostic Laboratory. She has been active in the field of biology, epidemiology, and diagnostics of sexually transmitted infections for 40 years. Her behavioral research focuses on delivery, utilization, and implementation of new diagnostic technologies. Dr. Vanderpool currently serves as the president of the International Society for STD Research. Next will be Bina Shanbhag. Bina holds dual master's degrees from the University of Mumbai in life sciences and from San Jose State University in biotechnologies. She has spent 16 years in the life sciences industry. She started her career in support organization and tech support and global product support roles where she focused on clinical applications. Subsequently, she transitioned to project management, overseeing implementation of application at key customer sites, managing global communications within reproductive health divisions, and coordinating action plans for customers with urgent support needs. Since transitioning to product management, she has managed and launched various products covering research, infectious disease, and clinical applications. She is currently a senior product manager at Thermo Fisher Scientific. Sangita Parikh holds a Master's of Science in Molecular Biology from the University of London in the UK and an MBA from Carnegie Mellon University, and has over 25 years of experience in product management, product marketing, and business development in molecular diagnostics and the life science research industry. She has managed and launched a variety of IVD and EUA assays and infectious diseases, as well as solutions for life sciences research. Currently, Sangita is a senior manager of product management at Thermo Fisher Scientific. We will begin with Dr. Vanderpool and her thoughts on STI testing and which tests should be offered at which point.
I'm going to talk to you today about STIs specifically and what the options are and what you should be offering to your clients, because this is an ever-evolving landscape and there's a lot of issues associated with what choices you want to make. I always do start with a disclosure slide. I work with a large number of manufacturers as well as government agencies through grants to my institution as well as consulting fees that I receive personally. So I'm going to cover a few topics today. I'll focus mostly on pathogens and the way that we diagnose those pathogens. I'm not going to talk a lot about diagnostic methodologies because I think probably most of you are familiar with those, but I'll be happy to take any questions on those topics if you have them. I'm going to talk about sample types that can be used for this testing, and then I'll end up talking about the ways that we can collect samples in today's world. So let's get started with the menu. So I'm going to focus first, and most importantly, in my opinion, on STIs that can be detected with molecular technologies or nucleic acid amplification tests. I'm going to give you a little bit of the epidemiology of the things that I have on this particular slide, just so that you'll remember why you get large volumes of these requests. So to start with chlamydia and gonorrhea, it's important to remember that these two infections alone account for over 80% of all non-COVID notifiable infections. That's a lot. These are highly prevalent infections, and that's why we have screening programs, which I'll discuss in just a minute what the recommendations for screening are. Chlamydia is predominantly asymptomatic, which again is why we have screening programs where I use screening to talk about testing asymptomatic populations based on predetermined criteria, but not symptoms per se. Gonorrhea is often less commonly asymptomatic, especially in men, but women still do have asymptomatic infection. Trichomonas, which is caused by Trichomonas vaginalis, can be, we often hear trichomoniasis, and this is more common than chlamydia and gonorrhea combined in many populations. And so it's really important that we consider testing for this when we test for chlamydia and gonorrhea, and most tests that are commercially available now do have a trichomonas testing option. I don't say trichomoniasis for the most part because as many as half of these infections may be asymptomatic. And that means that people don't have trichomoniasis, which is the inflation and infiltrate that's caused by that, but they do carry the disease. And it has outcomes during pregnancy and risk for HIV that are similar to those related to chlamydia. And the prevalence is much higher, so it's an important pathogen for us to think about. Mycoplasma genitalium, you've probably been hearing a lot about for the last 2 to 5 years. I've been testing for it for over a decade. The problem with it is we don't have great data from an epidemiologic perspective to associate this infection with downstream outcomes. So we're not really 100% sure that treating patients offers an advantage in protecting them or in protecting women and neonates during pregnancy. It's important to think about the fact that 40 to 80% of Mycoplasma genitalium detected in this country, which isn't a lot, we don't test everybody, but 40 to 80% of those cases have a resistance marker to macrolides, and those are the antibiotic class that's used for treating chlamydia. So we may be driving resistant Mycoplasma genitalium in our chlamydia control efforts, and I'll talk more about that in a bit. Finally, on this slide, I've included causes of vaginitis because this is the single most common reason that women seek health care. And obviously, we would do testing for women only in those women who had symptoms because BV, as you know, is an imbalance in many of the organisms that are commonly commensals in the vaginal microbiome. And the same thing obviously is true with Candida species that may be present normally, but when the woman is symptomatic, that means there's an overabundance of some of these bugs, and that's causing problems. So that's diagnostics that should be done, not screening, because it should only be done in symptomatic women. And I mentioned that I would go over the CDC guidelines, and I'll start with chlamydia because it's one of the ones that we have the clearest cut guidelines for. In this case, because of the asymptomatic nature of infection, we recommend screening for women, any woman under the age of 25, regardless of sexual behaviors, regardless of numbers of partners, regardless of new partners, really regardless of anything. If you're under the age of 25, you should be offered chlamydia screening every year at an annual healthcare visit. But also, in women without symptoms, the CDC recommends screening in certain cases, and I've called this for cause. And in green here, I'm showing what those for cause reasons are. We define those as people living in a high prevalence population, which often the lab can't know, so this is really difficult for us. Having a new partner, having an infected partner, which again, the lab is not going to know, and people who are on PrEP, where recommendations exist for screening those people 3 to 4 times per year. Obviously, diagnostic testing should be performed on anyone who has symptoms related to chlamydia, which you're going to see these are the same symptoms for all of these bugs: discharge, dysuria, and other related symptoms like pelvic pain, tenderness, so on and so forth. Okay, so Neisseria gonorrhoeae, which we usually in this country test for with chlamydia, in Europe they don't test for as a routine necessarily because asymptomatic screening is not actually recommended. Now again, that's screening for cause, if you live in a high prevalence population, so on and so forth, is appropriate. And obviously, testing anyone with signs and symptoms is appropriate. So we often bundle chlamydia and gonorrhea here, and we do find a lot of asymptomatic cases, which is why it's the second most common notifiable infection. Trichomonas vaginalis, which, by the way, is not a notifiable infection, which is why we don't have good epidemiologic data on that organism. But the CDC guidelines only recommend screening women who hit those 4 cause categories. So essentially, this is the same as for gonorrhea. However, they only recommend testing in symptomatic people if chlamydia and gonorrhea have already been ruled out. We'll see in a minute that because Trichomonas is so prevalent, and because chlamydia, gonorrhea, and Trichomonas can be often occurring in the same patient, most of the people that I work with have decided to just include chlamydia, gonorrhea, and Trichomonas, 3-part screening for women who have symptoms. So sorry, that's not screening, that's diagnostics. Now, for Mycoplasma genitalium, the CDC does not recommend screening. And to be clear, I'm not saying they don't have recommendations about when you screen. Their recommendations say you should not screen asymptomatic people. Again, that's because we don't know the best treatment, and we don't have data that's convincing data that there are adverse outcomes to untreated asymptomatic infection. And for people who present with symptoms, they recommend Mycoplasma genitalium testing only for those who have failed chlamydia gonorrhea treatment or were negative for chlamydia gonorrhea after testing. Now, this obviously involves 2 patient visits and a lot of extra clinical healthcare resources to be utilized. So it's not an ideal situation. But again, as I mentioned earlier, we have antimicrobial resistance issues with this organism, and so treating it can be problematic. I told you I would share with you information about co-infections, and this is really great data from Damon Getman and colleagues several years ago. It's important to remember that first, this is from symptomatic patients only. So we're looking here not at the prevalence rates of these diseases, but if a symptomatic person comes in, the proportion of those people that have these infections. And what you see for women, shown here in green, is that the vast majority of them have Trichomonas, which again is why many situations in clinical settings and STD control programs automatically test for Trichomonas when they test for chlamydia and gonorrhea. Interestingly, Mycoplasma genitalium is the 2nd most common, and chlamydia comes down here as a very far and distant 3rd. And again, this is patients with symptoms. You'll see that GC alone is very rare, but it also occurs with other infections. So testing for all 3 or even 4 pathogens, if you want to include Mycoplasma genitalium among symptomatic people, may be warranted. We just need initial data about what's happening with people who have symptomatic Mycoplasma infections. And the guidelines for CDC do require that you use an antimicrobial resistance marker detection assay. We don't have any of those available in the US. If you're working in Europe and you have access to those assays, then you're much better ahead because you can make targeted decision about how to treat people. For men on the right, you can see that the most common infection is chlamydia, followed by Mycoplasma. But interestingly, Trichomonas is very common in men who have symptoms, 14 to 15%. So don't forget that testing those people for Trichomonas while they're at that initial visit so that you can treat them appropriately the first time may be warranted. So that's what we know about co-infections. And I did mention earlier that we should be considering causes of vaginitis when we're testing patients, women that have symptoms. And this is just a study to show that the data are quite strong, showing that if you have, for example, bacterial vaginosis, 17% of those people are going to also have an STI. So doing just vaginitis testing or just STI testing doesn't tell you the whole picture of what's going on in a woman with symptoms. I did want to mention a few other pathogens that you can put into bundles. I've already said our process of bundling chlamydia gonorrhea may not be ideal, and it's not always that way in Europe. Also, that bundling in Mycoplasma doesn't make sense because you're testing a lot of asymptomatic people. But I wanted to talk about some of the other assays that are commonly offered from either a urine specimen or a vaginal swab. The first of these is herpes simplex virus, but I would argue that if that's from a urine specimen or a vaginal swab that's not directed to a lesion, those results are likely uninterpretable by the clinician. The reason for that is if you get a positive result, it's probably a true positive, but it may be detecting asymptomatic shedding. And in that case, the provider is not going to want to provide suppressive therapy. So that result wasn't helpful. If, on the other hand, the result is negative, that doesn't mean that the person doesn't have HSV, because we know that HSV can occur in what we call that boxer short region. So it might not be located in the vagina, and it might not be located in the urethra from which the urine was provided. If that's the case, the negative result is again accurate because we can only detect what's in the specimen, but the result's not meaningful. And so especially when we start talking about remote sample collection and lab-based testing, this is one that offering is probably fraught with difficulties, and you should really consider. Excuse me. So other things that we should consider. A lot of people have been asking about syphilis PCR lately, and they would really like a solution that's molecular for detecting syphilis. The problem with that is we don't have enough data to tell us where the spirochetes are during different stages of the disease, which does go through very specific developmental stages. So one of the problems is that if a person has a positive result, again, it's probably meaningful, but a negative result is probably not. So if we have a urine specimen that gives us no syphilis DNA, that doesn't mean the person doesn't have syphilis. And I apologize for all those double negatives. But the reality is that this is not ready for prime time yet, and people will keep working on that. But until we know where the spirochetes actually are during the various stages of infection, it's very hard to develop an assay that's useful for detecting syphilis with molecular technologies. And then I want to just briefly say Mycoplasma hominis and the ureaplasma species, Ureaplasma ureolyticum and Ureaplasma parvum, have not been shown to be associated with negative outcomes either during pregnancy or related to fertility or development of epididymitis or proctitis. So there's not really a great incentive for treating those. And in fact, what we know about Mycoplasma hominis is that it increases in organism load during episodes of BV, but it decreases in organism load in response to treatment for Gardnerella vaginalis. Now, Mycoplasma hominis doesn't respond, it's not susceptible to that class of treatment, and yet the organism load decreases. We think this is probably because the organism is happily replicating inside the biofilm created by Gardnerella, and when that biofilm goes away, that replication environment's no longer as friendly and the organism load goes down. But my point here is we have to be cautious that just because there's an epidemiologic association doesn't mean it's causal, and doesn't mean that we want to do diagnostics, and certainly doesn't mean that we want to engage in therapy for these infections if they're not really infections. So I'm just showing here, again, I'm not going to talk a lot about methodologies, because if you have a lab and you're already doing this, then it's all good. But this is the sort of scope and range that we have right now. We go from the mini school bus size shown here on the upper left down to something that you could hold in the palm of your hand. So it's all fine that you can use these different point of care options to a lab-based option, and even these point of care options can be used in a laboratory. So I just want to say a word, since I've mentioned point of care, I want to say a word about antimicrobial resistance markers. And there have been a lot of people recently who've been saying that antimicrobial resistance marker testing is only useful at the point of care, so the patient can be treated before they leave. And while that's a great thing for gonorrhea, and in fact, we know that if you use a gonorrhea test at the point of care, and you can detect that the JAR-A gene is wild type it's susceptible to ciprofloxacin. So you can treat patients with an oral therapy rather than having to use an injectable like ceftriaxone, which is currently the recommended treatment scheme. So yes, at point of care, that works great. And here's an example of one of the assays that's sort of in development, where you would have just a little box that would tell you in red here that the gonorrhea is present. In blue, you see that it's wild type, so you could treat with ciprofloxacin. In the middle panel, you don't see that blue line, so you would have to use ceftriaxone. And in the far right line, you see that there's actually no gonorrhea in there, so you didn't have to treat. Of course, the problem with this is it's only testing for gonorrhea. So you don't know about chlamydia or trichomonas or mycoplasma. So that's where the lab is always going to have to come in and backstop whatever the point of care options aren't telling the provider. So lab-based testing, excuse me, is also appropriate for Mycoplasma genitalium always. Because in Australia, they've adopted a staged program of treatment, which they call resistance guided therapy, where you test people first, you give them doxycycline, and again, this is only symptomatic people, doxycycline for 7 days, you look at the test results. If Mycoplasma is not there, if they have trich, you still need to treat the trich because the doxycycline wouldn't have done it. If they have gonorrhea, obviously you need to treat that. But if they have Mycoplasma as well as any of those other things, you need to treat depending on the macrolide resistance marker results. So if they have wild type, you can use azithromycin, and they had a 95% success rate in this large clinical trial. If they do have the markers saying that they're resistant to macrolides, you can treat with moxifloxacin, which is A, more expensive, and B, has worse side effects. So it's not what you want to go to as your first line therapy. But then they still have a 92% plus cure rate. So it's really awesome. So now I'm going to change topics from molecular diagnostics, sort of, to serology. And I say sort of because with HIV, as you all know, serology is the routine screening diagnostic method, usually with a generation 4 or 5 antibody antigen combination serology test. But more and more, we're starting to need RNA, viral load, molecular testing, because many of the people being tested now are on PrEP, which means they were tested recently, let's say within the last 3 months. So you're looking for incident infection. If you're looking for incident infection every 3 months, you might be looking before a person actually develops antibodies. And so therefore, something that can detect the actual organism is probably more useful. For syphilis, serology remains the most common and the appropriate diagnostic method. There are two types of serology that you have to do: treponemal specific antibodies that will be positive for a lifetime if you've ever had syphilis, even if it was treated, and non-treponemal antibodies, which the serology tells you if the person has an infection, but doesn't necessarily identify it as a syphilis infection, which is why you have to have both. And you can do the reverse algorithm, which is the order that I've shown here: treponemal followed by non-treponemal. If you have a low prevalence population, that probably is cost savings. But if you have a high prevalence population, you're going to have a lot of people that are going to have treponema positive results. So probably starting with the non-treponemal test is more important and probably saves you some money. Okay. Hepatitis B and C, we're still obviously doing serology tests to detect these. Although again, with hepatitis C, we're moving into that molecular realm where we want to see viral loads in order to determine whether it's an active infection. And then again, a word about herpes, sort of the STI problem child, if you will. Herpes serology is kind of fraught with difficulty. Probably it makes sense to do only antibodies specific to HSV2. However, none of the tests that we have are supremely sensitive or specific. And so what you need to do is you need to confirm that it really is HSV2 and not antibodies to HSV1 that might be cross-reacting. So confirmation is absolutely required if you're offering this test. And if you're not offering this test, think twice before you offer it, because really HSV antibodies aren't terribly meaningful clinically again. So if a person is positive for HSV2 antibodies, if they don't have lesions, then you're not going to treat them based on that positivity. If they were somebody that you were going to test anyway, clinically, you're probably already counseling them about how to protect themselves and how to protect their partners from HSV transmission. If they do have lesions and you do the test, but the HSV2 test is negative, that's not very meaningful either, because more than half of genital herpes is now caused by HSV1. But of course, as we know, since cold sores can also give you antibodies to HSV1, testing for HSV1 doesn't make sense. So all the way around, herpes is just really fraught with difficulty, and one should use caution before adopting it. So what are you supposed to be offering? Because that's part of what I said I would tell you. Well, I can't tell you. First of all, though, you have to disentangle screening from diagnostics, which we've never had to do for chlamydia, gonorrhea, but because Mycoplasma is out there now, you probably need to start asking for information from providers about the symptomatic status of patients. You should have a full menu so that you can offer your clients whatever they want, but you probably shouldn't do automatic bundling. And you'll need to really work with your clinician colleagues to try and decide what's best in terms of tests that you offer in terms of patient outcomes. I think that this is becoming more important than it's ever been before in the STD arena. So with that, having not answered your questions at all, let me transfer over and talk for a minute about sample types. So in 2009, we actually wrote guidelines for laboratory diagnostics. It took 5 years to get them published, and they were released in 2014. But a lot has changed since then. So we say a couple of things. Even in 2009, we knew vaginal swabs were the optimal specimen type. We knew that male urine was the preferred specimen type to invasive urethral swabs, but in green here I put something that's not in the guidelines, which is that meatal swabs may be useful. We need to do more work on that. So right now, only one assay has a claim for meatal swabs, and only for one pathogen. So meatal swabs aren't ready for prime time, but be thinking about them because they're probably going to come your way. Anal, rectal, and oral pharyngeal sampling is quite important. If you're doing oral pharyngeal sampling, you do need to make sure that people are aware that they can't do a buccal swab. It has to be a tonsillar pill-eye swab. And again, not in 2009's guidelines, but the things that we know today is that we don't have anywhere near enough data to make recommendations about the best anatomical sites to sample in trans persons. I just wanted to give you a little bit of data about why I even talk about sample types, and I'm really pretty passionate about this. But in a survey done in 2020, still over half of samples coming into public health labs for STI screening from women were urine. And I've shown here a bar graph that shows you in red the sensitivity of vaginal samples and in yellow the sensitivity of urine. And these sensitivities are statistically different. And it's important that we offer the best service that we can to our clients. So offering vaginal swabs is quite important. But if you have to offer urine, and there are times when it makes sense, but if you have to order urine, please do not send residual clean catch urine, because these are terrible sample types. All of the material that we want to detect for STIs is in that first void portion. So when we look at the numbers, this great study from Pickett and colleagues showed that compared to vaginal swabs, a clean catch urine is missing 20% of infections. That's not good health care. That's not what we want to offer patients. So if you have a lot of clients that are still sending you urine from people who have a vagina, ask for vaginal swabs and share with them data and explain to them why it's important. And in fact, if they use self-collected swabs, which I'll get to in a minute, they can actually improve their clinic flow. I did mention that you should be doing extragenital sampling, and here I show you data from 14,000 visits to a health department clinic in Indianapolis. And in this study, anybody who reported receptive anal intercourse was sampled. And what we saw is that if you don't sample the anal rectal specimens from men, you would miss 70% of chlamydial infections. You would miss over half of gonococcal infections in men. Now, in women, these numbers are much less striking. Most women's rectal infections are likely autoinoculation. And the other thing, I'm not showing the pharyngeal data here because we did pharyngeal testing, but what we found was that the vast majority of people that had an infection in the pharynx also had either a rectal or a genital infection. And so doing those two sample types was likely enough to get the vast majority of infections. So again, when you're doing extragenital testing, you need to avoid the bundling. It's really a consistent message I'm trying to share with you here. For chlamydia and gonorrhea, it's quite easy. 3-site testing is recommended based on the exposures of the patient. And again, as a laboratory, you don't know this, but it's helpful sometimes if you can share this with your clinician colleagues. It's important that they not order Trichomonas routinely because we don't really have a sense of the meaning of a Trichomonas positive in a rectal sample and a throat sample. There are commensal organisms that may cross-react in some of these assays. They've not been validated. They don't have claims. So this is something that's probably useful for genital testing only. And then for Mycoplasma, again, the genital testing is limited to those people who meet the right criteria. Anal testing is done a lot, especially in places like Australia. And in gay men, you will find a lot of Mycoplasma. You will also find that almost all of it is resistant. So these people would predominantly need moxifloxacin treatment, but we don't have the tools yet in this country to allow us to offer that AMR testing. And therefore, since people don't really know how to treat it, most health departments are not recommending it, and the CDC certainly isn't. So one of the things that we clearly need is AMR detection. Okay, I told you I would move to self-collection, and that's what I want to end by talking about for a few minutes. And essentially, self-collection can be done in a clinical setting, which is what everybody has claims for vaginal swabs, nothing else. Well, urine, of course. But really, self-collection can be done in non-clinical settings as well, but unfortunately, none of the assays that we have those claims. And we'll talk more about that in a second. I do want to be very clear that I'm not talking about self-testing here. Self-testing is when the end user collects their own sample, does the own test, and interprets their own results, all without input from a healthcare professional. So these are not here yet, but they're on the way. So be prepared, because you're going to have people coming in that you're going to be testing that tested themselves at home. And when the results aren't the same, the lab is going to hear about it. So you need to know that it's coming. So self-collection in a non-clinical setting is really not new at all. We've been doing this with groups that I've worked with since the late 90s, and we've never had an adverse event reported, including working with adolescents. This is easy, this is safe, the results are appropriate and just work the same as things collected in a clinical setting. It is recommended that self-collection can be done since 2009's guidelines, but again, that was in a clinical setting. It's recommended by WHO as part of their self-care initiative. And self-collection, even in a clinical setting, is considered to be cost-effective. It's cheaper to have the patient go into the bathroom, provide a urine if they're providing a urine, provide a vaginal swab, and then go back to the waiting room or wherever until they wait and interact with the provider. And that saves time on the provider's part because those specimens are already sitting there waiting. Once we have point of care tests, which we do now, in fact, those tests can actually be run. Sometimes the results can be available to the provider before the patient even goes into the room. So it can really improve flow, and there are cost savings associated with it. As far as extragenital testing goes, again, assays have claims for these sample types, but not for self-collection. And so that's something to be aware of. In most cases, we sort of don't ask, don't tell in the lab, because we know that most patients prefer to collect their own rectal sample, and most providers prefer to allow them to do that. And this is just from a study up in Indianapolis where we asked people to do this and then asked them what they wanted to do in the future. And most of them wanted to do their own sampling. Throat sampling is a little bit dicier because people might give you buccal samples and then a negative isn't terribly meaningful, but you need good collection instructions if this is going to be adopted. And although this is a clinical activity, Often providers will look to the lab and say, can you give us instructions for how to collect these? So laboratorians need to know what the best way to collect these samples is. And many places have resources like the one shown here. Some places even use videos that the patient can watch the video as they're actually doing it and look in the mirror and make sure that they're doing the thing correctly. So lots of resources out there for doing this. So let me wrap up and just remind you that one size really doesn't fit all. And while we try to give our clients everything that they want, that's going to vary. It's going to depend on your client base. And I think it's really important that the lab work with providers so that providers really understand exactly what's being offered and for whom it's appropriate. Avoid bundling. Even if your platform does it and you're offering a full menu, which is wise, you probably need to avoid bundling. Trichomonas should be encouraged in most people. Vaginitis should be encouraged in symptomatic women, but Mycoplasma genitalium testing should be discouraged. So it's quite complicated. It's just never as easy as we would like it to be. So you should offer all sample types positive. You should discourage routine use of urine from anyone who has a vagina because you should get vaginal samples. You should consider the sexual routes of exposure, but you in the lab don't know. So again, this is where you're working with the provider to say, if you have clients who engage in receptive anal intercourse, our lab can support testing anal rectal samples. And again, as I mentioned earlier, a lot of people have these infections in the rectal compartment that wouldn't be detected by genital testing. And while I personally don't find oral pharyngeal testing to be really cost effective or productive, a lot of people ask for it. So I provide it, but again, only for chlamydia and gonorrhea.
Thank you, Dr. Vanderpolt, for your interesting presentation. Now Bina will present our STI clinical portfolio.
Thank you, Teddy, for the introductions, and thank you, Dr. Vanderpool, for an amazing presentation. I will be talking about our TaqPath Menu portfolio that supports STI testing solutions. Prompt and early diagnosis of sexually transmitted infections is important to enable appropriate treatment and help prevent further transmission. Clinical testing labs require STI testing solutions that help provide confidence, fast turnaround time, and accurate results. We just heard the importance of clinical STI testing, and I would like to present our TaqPath Menu GeneProof STI portfolio that will enable testing of STI pathogens. Here is our offering of 11 STI PCR products. We offer a solution to our customers which support sexual health testing with CE marked sexually transmitted infection assays designed to provide reliable results with excellent sensitivity and specificity across a wide variety of pathogens. We support multiple sample types from swab, urine to sperm, and we offer qualitative assays for all the 11 STI products, as mentioned on this table. This is the authorized workflow, which is a standard workflow used with real-time PCR assay. Once you receive samples, you can extract and prepare the specimens according to the instructions for use, followed by using the TaqPath Menu assays on the validated qPCR instruments, such as the Applied Biosystems 7500, QuantStudio 3, and QuantStudio 5 instruments. The analysis and interpretation is according to the IFU. Now let's talk about the benefits of the TaqPath Menu products that we now have available in our Thermo Fisher Scientific genetic testing solutions portfolio. When it comes to the TaqPath Menu GeneProof PCR kits, there are several benefits. Some of these benefits are quite unique. These benefits include simple PCR content, one workflow, excellent EQA panel results, ready-to-use master mix, unique internal control, contamination prevention system, and a wide range of verified specimens and instruments. Let's deep dive into each of these features. As previously mentioned, one of the benefits of our TaqPath Menu PCR kits is the simple kit content. Simple kit content means the kit contains ready-to-use master mix, internal control, and positive control. And in case of quantitative PCR kits, instead of a positive control, the kit will contain calibrators A, B, C, and D. The advantage of the simple kit content is that users do not need to mix their own master mixes from several components, unlike other manufacturers that use lyophilized reagents and need to prepare a working solution before adding the sample. This simple kit content provides all the reagents needed to run the PCR assay. Another benefit, and one of the best, is what we refer to as one workflow. One workflow is important because it means we have a universal PCR profile that is validated for majority of our PCR kits. The PCR profile works for RNA and DNA pathogens. With a universal PCR profile, we can very easily combine different assays in a single run. So we can combine assays from the same or different diagnostic groups. An example here is we can easily detect Chlamydia or HIV or HPV and other pathogens in a single run thanks to this one universal PCR profile. For lab users, one workflow can be extremely helpful for routine diagnostics, such as a single run can involve many materials, types, and many results which examine RNA and DNA pathogens at the same time. This is an example of one workflow and how it can be used to detect a causal agent for urethritis. Since there are many different pathogens that can cause urethritis, it is very beneficial to combine several assays in a single run. As shown in the previous example, samples are typically obtained via either a swab or a urine, and we add a universal internal control directly to these samples. So it's just one universal control for all the 3 PCR kits used here. Extraction is performed, and by using 3 assays and a single universal PCR profile, we can combine singleplexes as well as multiplexes assays together in a single run. In our example here, we are running the M.H.UUUP multiplex with the CT-NG-MG multiplex and a singleplex of Trichomonas vaginalis. With just one PCR profile and one single run, you can get results for 7 different pathogens. As an example here, these are all the assays that you can run together using the universal PCR profile on the Corn Studio 5 system. So you can mix STI assays along with other infectious diseases to run on one single instrument. And by using the universal PCR profile, you can mix and match different assays from different diagnostic groups to get a result for that one sample type. Another benefit is the ready-to-use master mix, which provides users all the necessary reagents for PCR reactions. The ready-to-use master mix simplifies the laboratory workflow for routine diagnostics. This means that users simplify the need to add extracted DNA or RNA, and then they just set up the PCR. The Applied Biosystems TaqPath Menu GeneProof Universal Internal Control is a separate product that can be ordered. It is very helpful, especially when you're combining more pathogens or more assays in a single round. Of course, users do not need to use it when they want to run a single assay, as that kit will have its own unique specific internal control as a part of the PCR kit. However, when they want to combine and simultaneously detect more pathogens in a single run, or combine more assays in a single run, the TaqPath Menu Universal Internal Control is an excellent option. A major issue in laboratories is the problem of contamination. To try to prevent contamination, we include 2 components in the ready-to-use master mix. By including an enzyme and uridine 3-phosphatates in the ready-to-use master mix, we can avoid false positive results and can easily prevent contaminations from carryovers from previous amplifications. Lastly, I would like to show you that our PCR kits are validated for use in a wide range of PCR cyclers. Again, this is just an illustration of that range and is recommended that you check the instructions of use for a particular PCR kit that is validated for, with use with that PCR cycler. Thank you. And with that, I think we have Sangita, Parikh to go over our research use solutions.
Thank you, Bina, for the introduction. Thermo Fisher Scientific has a variety of research use only solutions, and I would like to present to you today our TrueMark STI and vaginal microbiota research solutions. There are 5 formats available to provide flexible solutions depending on your needs. The single tube multiplex panel is a multiplex of 4 targets for STI. In addition, we have predefined 96-well panels covering an 8-target design. Available panels include STI plus panel, the vaginal plus panel, lesion plus panel, as well as the genital infection plus panel. We also offer 2 custom well formats. The 96-well format allows for the design of a 4 or 8 target panel, while the 384-well format allows for the design of a 12 or 24 target panel. In this slide, you'll see a more detailed view of the products being discussed. It covers the pathogens in each of the kits that were just presented. It also covers the kit components. Note that the kit components contains the assay as well as the one-step multiplex master mix that you will need. It also includes the format as well as highlighting the available controls. In addition, it lists the suitable sample type for each of the kits. It is recommended that you refer to the user guide. I would like to now present to you an overall product workflow. This is at a high level. It's applicable for all of the formats that you saw earlier on. First, the lab receives the sample, and please know that different sample types can be used. Next, the samples are then prepared for extraction according to the user guide. The extracted material is then run with the TrueMark assay kit on a real-time PCR instrument. These kits are suitable for use on our Applied Biosystems QuantStudio real-time PCR instruments. Finally, using the Design and Analysis Software 2.6, the data can be analyzed and a report can be generated. For the TrueMark predefined plus and custom panels for the STI and vaginal health, here are the benefits. The assays come as a convenient dried down TaqPath assays. There is the need just to add a master mix as well as the sample. The predefined panels cover 8 pathogens per panel. They're available on the 96-well format. Custom panels are available on the 96-well as well as the 384-well formats, enabling anywhere from 12 to 32 samples per plate. These TaqPath research assays are also available not only for vaginal health and STIs, but other disease areas, and all of them are optimized for maximal strain coverage and specificity. Each well contains a duplex reaction with both target and the control assay. And then, as mentioned, it is compatible with the Applied Biosystems QuantStudio real-time PCR instruments. For the TrueMark STI Select panel, this is the multiplex single tube format. This includes 4 of the most common and prevalent STI targets. RNase P is the internal process control, which adds to confidence. And the combo kit includes both the assay as well as the master mix, making it convenient for ordering. In addition, it is compatible with the Applied Biosystems QuantStudio real-time PCR systems. So with that, I will end the presentation.
Thank you, Sangita, for your excellent presentation. And thanks again to Dr. Vanderpool and Bina for their presentations. I'd like to thank everybody who has attended today's webinar. If you would like more information on the subjects that were covered, you can go to thermofisher.com.